I think it's important that we look at what is personality, because I think even till today, people look at the term personality disorder with disdain. Some professionals do not like anyone to be called a borderline or a narcissistic personality disorder. And I would like to try and banish those ideas by actually explaining in detail, as simply as possible, what is personality and what are personality disorders. I think in that respect, we've come a long way. There were pejorative terms in the past, but they need not be that way any longer. The other thing is that single personality disorders don't occur on their own. They usually are mixed. You may get personality traits of borderline and narcissistic personality disorder in the one person. You may get traits of 3 personality disorders in the same person. They have a great impact. For instance, if someone has an anxiety disorder and a personality disorder, they act both ways. Anxiety contributes to the development of personality disorders, and it can also affect the severity of the personality disorders. Like, for instance, if you look at people who have social anxiety, they tend to be also have avoidant personalities. They're both different. The social anxiety and avoidant personality are totally different, but they contribute to the development of each other, as well as to the resistance to treatment also. And more recently, the ICD-11 and the DSM-5 have, I think the DSM-5, in my own opinion, has made it even more complex, because they've described, we've always known DSM to describe categorical classifications. But with the ICD-11 and the dimensional classification, DSM-5 has also introduced some dimensional classification. So a way of feeling about oneself and interacting with others that is inflexible and pervasive, that causes distress to the individual, and that causes some amount of impairment. So if all of these features are present, we refer to it as a personality disorder. So we can't call it a personality disorder if we are attributing it to another mental disorder. Like, someone is depressed and they're feeling bad about themselves, their functioning is impaired, they're not able to continue going to university, or they're not achieving the same results, let's say, in university, then it's impairing their functioning. So another mental disorder is causing difficulty in their functioning. We can't directly attribute that to a personality disorder. Another very important advancement in the last 10 years is that personality disorder doesn't have its onset in early adulthood, as was claimed, for decades. It can be traced back to adolescence or early adulthood. And it's not attributable to the effects of a substance. So if someone has got substance abuse and substance dependence, it's important that that person is weaned off the substance and then their personality assessed before we can make a diagnosis of personality disorder. Of course, sometimes there are some glaring examples of borderline narcissistic personality disorder that, we can in fact make that diagnosis. So personality disorder is mostly conceptualized as a disorder of self and other in terms of relatedness. How one sees oneself and how one relates to others, when that is pervasive and inflexible and maladaptive, and causes significant distress to the individual and to the functioning of the individual. So these are currently the accepted factors when we describe someone as having a personality disorder. So this is just diagrammatically looking at aspect of self. So when we talk about aspect of self, we have a sense of who we are, our identity. As a person standing alone, as a person in relation to our, say, family of origin, or our current family, or our place of work, our sense of self-worth, and our capacity for self-reflectivity. So those are the important aspects of self. Whereas self in relation to others or interpersonal functioning is the ability to make and maintain close relationships that are mutually satisfying, that there's understanding of the other's perspective, and also the capacity to manage conflict in relationships. Now, sometimes one may be present without the other. They can start off by being mutually satisfying. They can start off by being very understanding of the other's perspective. But the managing conflict is in relationships. Now, when you talk about managing conflict, on the one hand, it can mean arguing with another person when in conflict, or it can mean accommodating to the other and accepting the conflict without further ado. So both are maladaptive. And so we really need to explore how people resolve conflict, because neither is helpful or adaptive. Now, if I was to summarize what we've been talking about now, the personality and personality disorders, they complicate not only mental illness, but as I said earlier, physical illness. And we need to look at personality disorders as related more to the type of attachment security that they've experienced in the early years. I remember Tess was 21 or 22, and she was avoidant, she was inhibited, and she avoided social interactions because she felt inadequate. And yet she wore an air of self-sufficiency. Now, often people with avoidant personalities may have some areas of where they suffer some deficits or imagined deficits. So they put on a mask-like appearance, an air of self-sufficiency, where they also talk about feeling judged by people. They feel negatively evaluated. And always talked about they feared ridicule or embarrassment. So when Tess was in therapy, she'd start to talk about things to do with other people, but not herself. And when this was, gently pointed out to her, what she experienced was a sense of shame. So the approach to such people needs to be done empathically at a point where they'll experience less shame. But inadvertently, sometimes we can provoke shame in such individuals, whether they're avoidant or they have a borderline or dependent personality. So it's important to reflect what we experience. Like sometimes I wonder if it feels useless letting me know what you're feeling or thinking about. Or I wonder sometimes if you feel that I might judge you if you were to tell me more about yourself. Are ways in which we can try to get patients to stop their avoidant style and to be more trusting. So the trust is always one of embarrassment. I fear being embarrassed if I made a mistake or if I made a wrong choice of words or I said something that was stupid. So you find that there's a lot of psychopathology related to the way they feel about themselves. and therefore the way they feel about others. So it's important to understand personality in every patient we see, because at the beginning, our engagement depends so much on how we relate and how patients relate with us from the very beginning. You'll also find that personality interferes with treatment compliance.